dear chairs, dear audience, it's my great pleasure to be here. I would like to thank organizers, Jolie and Jolt, for inviting me here and giving quite difficult topic for me. And at the very beginning, I must disclose that I am not an expert in brain monitoring, but rather critical enthusiast of it and quite fresh user of some techniques. And why here, why now and here brain monitoring? Because sepsis affects brain, and usually, it is not encephalitis. Encephalitis is not most common problem. Usually it's sepsis-associated encephalopathy, which is caused by deleterious inflammatory host response to infection. And you can see various mechanisms here. And the clinics is altered sensorium. The mildest form, perhaps you know very well, sickness behavior, because we may experience it during a flu, for example, at our home. Yeah? We are unable to perform complicated intellectual tasks. But for ICU, the most relevant are delirium and coma, and sometimes seizures. And I should start with that and saying also that this sepsis-associated encephalopathy contribute not only to increased mortality, but also contribute to negative outcomes, functional outcomes in sepsis survivors. And another important link, very often sepsis leads to ARDS and lung protective ventilation can also negatively impact brain. But we should start from regular clinical assessment, and still the mainstay of our patient management is regular classical neurological examination, and please try, if it is possible, to stop sedation to have a valuable result. First, very important problem, delirium. It's not isolated problem. The concept started from 3 interrelated problems: pain, delirium, and agitation and sedation. But now this concept evolved into 5 ICU ailments, but I would say ICU nightmares: pain, agitation, delirium, immobility, and sleep disruption. And talking about delirium, dealing with delirium, we start with pain. And I must repeat very nice quotation from Lord Kelvin. If you want to improve it, you must measure it. So pain, agitation, delirium should be assessed. And we have the problem with our patients because only some of them are cooperative, and we have good scales, like NRS for that. And for the rest of them who are unresponsive, we have behavioral scales. They are not so difficult. They are based on the assessment, observation of facial expression, upper limb movements, compliance with mechanical ventilator, and in spontaneously breathing patient vocalization. But it's still quite difficult to introduce into clinical practice. Ideally, the assessment should take place 4 times per shift per 12 hours. And I must be honest with you, in my department, it's once a day and only by doctors, not by nurses, and not always, and this is BPS. And we have a threshold for therapeutic intervention, and of course therapeutic intervention is based on opioids in ICU. Sedation should be also monitored. In Poland, I think that all over the world, the RAS scale is the most commonly used. And of course, ideally, it should be between -1 and +1. We accept -2, and we have the exception, which are patients, neurointensive care, very severe respiratory failure, when patients should not combat with ventilators and it's difficult to set ventilators. But if I ask my doctors sometimes, what is ideal RAS, the answer is perfect from -1 to +1. And then I ask another question, why every day it's -3 or -4? This scale, we can omit this, very similar. And finally, delirium assessment, and this is still in my plans, I think, because it's quite complicated again. We have 4 items. First of 2 are obligatory, yes, to diagnose delirium if we use ChemICU flow sheet. So you can see here, acute change or fluctuating course of a mental status. In responding patient, then inattention, so we spell slowly the word like Casablanca, for example, and ask to squeeze a hand, hearing A, ask a patient, or there is alternative picture test. So it's already quite complicated. And 3 or 4, 3 is altered level of consciousness. It's very simple, RAS other than 0. And 4, disorganized thinking, so wrong answers to the question such as, will a stone float in water? And this is a task for my ICU, and I think for a lot of ICUs in our region. This is performed in the United States in many, many ICUs by nurses. And it's not enough, because we should assess the current status of the patient, but we should set up a target, where we are going, where we are now, where we are going, and how we get there, what happened that the patient is delirious. This assessment, pain, agitation, delirium, is in fact incorporated in the bundle of care, and this bundle of care, A, B, C, D, E, F, ends with E, environment, and F, family and engagement. And still we have a lot of work to do in our part of Europe to improve these 2 components. But data are there, because observational studies, but quite large, showed that sticking to this bundle saved lives. Shorter ICU stay, shorter hospitalization, lower mortality. So that's the part of clinical assessment, not only clinical examination, but by delirium assessment and in fact PAD, PEDIS, ABCDEF. And my second part is neuromonitoring, and of course that's our favorite word in anesthesia and intensive care, multimodality. Yeah, it's a very famous word. So here again, electricity, electroencephalogram, plumbing, so fluids, blood, CSF, structure, imaging, and biochemistry. I will say a few words about electroencephalography, and that's very difficult for us, especially raw signals and full montage, I mean these multi-electrode conventional systems. In fact, I feel it's unacceptable for me. Especially, I know, need continuous monitoring. Yeah? So maybe the way to go is processed signal, and the way we already use in clinical practice, quantitative measurement. Bispectral index is, I think, something you know better than me. Of course, there are a number of indications. Seizure detection, of course, assessment of patients with encephalopathy, especially comatose patients with unexplained and persistent altered consciousness. And sometimes electroencephalogram may herald cerebral ischemia. Bispectral index might be used for sedation, not only for anesthesia, deep sedation with neuromuscular blockade, and sometimes may supplement also the clinical assessment in not so deeply sedated patients, but it's rather not recommended for monitoring of sleep. And processed electroencephalogram, in fact, we have data and quite firm evidence, scientific evidence supporting sedation monitoring, depth of sedation monitoring. There are still, these tools are not so perfect to detect seizures, especially non-convulsive seizures, and closed-loop anesthesia systems, okay? And I found this EEG spectrogram quite attractive. It's quite complicated from the computational point of view, fast Fourier transformation. And so on the right bottom, you have the graph we should look at. On the horizontal axis, we have the time. On the vertical axis, we have the frequencies of the waves, and colors depicts the power, which is calculated from amplitude. And having these pictures, we may observe specific signatures of sedatives and anesthetics. We can observe, of course, suppression of signal, because suppression of signal is this black area with small blue line, and it should be differentiated from white areas, which is a loss of the signal because of technical reason. And in fact, here are burst suppression, because you have the periods of activity and inactivity. And finally, the seizures can be seen as these flames, cyclic flames. But you should look at it. There is no number, no alarm. So that's an obstacle. Of course, there are sepsis-associated encephalopathy, EEG classifications, but I don't think they are very important. And there are possibilities also to introduce EEG outside ICU and inside ICU using special systems, but I am not an expert in it. We may supplement EEG monitoring with oxygenation, and I am sure you from TBI know invasive systems, but I will not focus on invasive systems, but quite old system, which is near-infrared spectroscopy and cerebral oxygenation, not measurement maybe, but estimation in fact, but dynamic changes are important. Normal values are usually more than 60%. They are prone for errors, these techniques, but you can use them together with EEG. So on the bottom, you can see here the regional oxygenations from both hemispheres, together with EEG spectrogram. And just to finish, to say a few words about other techniques. Automated popularimetry, infrared, we have this technique. I found it useful in evaluation of comatose patients. You have really precise recording of the reaction of the pupil to the light in a form of graph and special index. So that's quite interesting, and this can make our clinical examination more objective. This is a lesson to do for my department, to introduce the point of care ultrasound for the brain. And I think the optic sheath nerve diameter, that's not enough. It's only herald about ICP increase, so intracranial hypertension, but transcranial Doppler should be the way we should follow, and we should introduce it to the point of care ultrasound examination, because there is a lot of information here about blood flow, about cerebral vasospasm, estimation of ICP, and diameters of third and lateral ventricles. Even algorithm exists how to use transcranial Doppler. And intracranial pressure direct measurement should not be forgotten. And in my view, what we should do, we should measure invasively in every patient in whom neurosurgeons already put the drain, placed the drain into the ventricle, because there is no additional risk. And we do it in my department, this measurement. And finally, cerebral autoregulation, very specialized subject, but having NIRS, oxygenation, and mean arterial pressure, cerebral perfusion pressure, If your oxygenation is stable despite the variation in mean arterial pressure, cerebral perfusion pressure, it means that autoregulation works. So to conclude, sepsis-associated encephalopathy is an important clinical problem, and it may result not only in mortality, but also lead to long-term sequelae in sepsis survivors. Still, clinical assessment is mainstay of critical care. Neurological classic examination, but it should be supplemented by pain, agitation, delirium assessment. Neuromonitoring may supplement conventional neurological examination and inform clinical decision, and PROCIST EEG monitoring system are available, are potentially useful, but they have limitations such as scarce evidence, possibility of error, possibilities of misinterpretation, and need of training. Thank you very much.